First of all, I'd like to welcome on behalf of MedPiper. So I'm Trivedi from MedPiper. So on behalf of MedPiper and JournoMed, I would like to welcome all the respected speakers and all the attendees for IRIA Kerala session on case presentation in gastrointestinal radiology. So I'd like to hand it over to Dr. Venu to take it forward and make the case presentations.
Okay. Thank you. Good evening to all for this session. Today being Wednesday, no, this is actually the day of residents. And after covering pulmonology in January, in the month of January, and then cardiology in the month of February, and we are entering the third month in March. Here actually we are starting gastrointestinal radiology. And today the residents are Dr. Amjada and Dr. Deepika, and they are junior residents from Gokulam Medical College, Trivandrum. And they are being guided by assistant professors Dr. Vijay Kumari and Dr. Praveen Keshav, and also HOD, the head of the department, Dr. Harikumaran Nair. I welcome all of you to this session. And also in this context, I welcome Dr. Gomati Subramaniam, President Kerala Chapter, Dr. Rijo Matthew, Secretary Kerala Chapter, and also Dr. Ramesh Shenai, Program Coordinator, and also Dr. Rishmi, and she is the zonal coordinator, and she is the one who is behind all this session. I welcome once again all of you to this Wednesday program. And now over to Dr. Rishmi.
A very good evening to all. So welcome back to the academic session of Kerala IRI. So from this month onwards, as Venus had told, we'll be covering academic sessions on gastrointestinal radiology after having finished chest and cardiovascular radiology for the last 2 months. So as you all know, gastrointestinal radiology is a very important topic as far as exams are concerned and also the practical points. So what we have planned is that we have divided the whole gastrointestinal radiology into 2 parts. So first month, we'll be covering the topics related to hepatobiliary system and pancreas, and the second month, rest of the gastrointestinal radiology, including bowel. So residents, please make maximum use of it. We are trying to cover maximum topics in these 2 months. So today we have PG case presentations from Gokulam Medical College and Research Foundation. This session will be moderated by Dr. Harikumaran Nair sir. He is the head of Department of Radiology, Gokulam Medical College and Research Foundation. He is the Dean, Faculty of Medicine, Kerala University of Health Science, and is the former head of Department, Trivandrum Medical College, as well as Alappuzha Medical College, and he is the former joint DME. And the cases will be presented by 2 final year residents from Gokulam Medical College, Dr. Amjada and Dr. Deepika. It will be guided by Dr. Vijay Kumari and Dr. Praveen. Both are assistant professors in Government Medical College, in Gokulam Medical College. I think Hadisar is just joining. So we'll start the case. Amjada, are you ready? Can you start the case? Who will be presenting the first case?
Deepika is going to present.
Deepika or Amjada?
Yeah.
Ma'am, I'll be presenting the first case.
Okay, fine. And this case will be guided by Dr. Praveen, right?
Yes, ma'am.
Okay. Then over to you both, Dr. Deepika and Dr. Praveen. You can share the screen, right, Deepika?
Yes, ma'am. Good evening. So I'll be presenting the first case. Presenting the case of a 49-year-old female patient who came with complaints of intermittent epigastric pain for the past 2 years, loss of appetite and loss of weight, a weight loss of 9 kg over the past 2 years. So comorbidities include diabetes mellitus for 5 years, systemic hypertension, and dyslipidemia. On examination, she had no pallor or interest, and her GAT examination were normal. Laboratory investigations revealed a normal hemoglobin and total count. A liver function test revealed a mildly elevated direct bilirubin of 0.6 and an elevated alkaline phosphatase of the value of 533. Renal function tests were normal. In view of epigastric pain, a suspicion of acute pancreatitis was made, and amylase and lipase were sent for, which were within the normal values. The CA 90.9 values was sent for, which revealed a normal value. An ultrasonography of the abdomen was taken, which showed features of chronic calcific pancreatitis. There is a dilated main pancreatic duct measuring approximately 15 millimeter, with calcifications within the duct as well as a parenchyma, and with fatty replacement of the pancreatic parenchyma.
Right. So, Deepika, in this case, based on the history and the ultrasound finding, obviously we don't have the ultrasound images, but with these findings, positive findings, what are your differentials?
So with respect to the pancreatic pathology, and in view of the epigastric pain, the first suspicion would be that of an acute pancreatitis. But however, the amylase and lipase were within the normal limits. And in the ultrasound features are suggestive of a chronic calcific pancreatitis. So the features more in favor of a chronic calcific pancreatitis with probably an acute
acute on chronic pancreatitis.
Acute on chronic pancreatitis.
Right, good. So how would you like to proceed further?
As part of further evaluation, would like to go ahead with the contrast enhanced CT.
Just a moment. So on the ultrasound image, you also mentioned that the main pancreatic duct was dilated.
Yes.
And how much was the diameter?
So 15 millimeter.
Right. So 15 millimeter dilatation of the pancreatic duct. What additional differentials would you consider with this ultrasound finding?
The additional differentiate would include an IPMN, an introductive papillary mucinous neoplasm, where the ductal dilatation would be more than 5 mm. And you can also suspect a pancreatic adenocarcinoma, although the CA 19.9 levels are normal. A pancreatic adenocarcinoma would also cause a significant ductal dilatation.
Yeah. So we are suspecting pancreatitis and CA head of pancreas or an IPMN.
Yes.
CA 99 and amylase lipase are normal. Fine.
Yes.
So we are localizing our disease towards the pancreas. How would you like to plan your CT?
So initially, a non-contrast CT is essential. Look for any pancreatic calcifications, look for any hyperdensities, any hemorrhage within the area, followed by the late arterial phase, which is taken approximately 25 to 30 seconds, or the pancreatic phase, which is taken between 30 to 35 seconds. These phases are specific for detecting any pancreatic pathology, followed by the portal phase at 40 to 50 seconds, and the venous phase is 60 to 70 seconds.
Right. So good that you mentioned the timings along with the different phases. And let's proceed with the CT findings.
Contrast enhanced CT abdomen was taken for the patient. This is the non-contrast axial section image of the abdomen. You can see diffuse dilatation of the pancreatic duct measuring approximately 18 millimeter. There is complete atrophy of the pancreatic parenchyma with fatty replacement. Multiple large chunks of pose calcifications are seen predominantly in the region of the tail of the pancreas. Few fine specks of calcification seen in the head region of the pancreas. This is the post-contrast venous phase axial section. So you can see there's dilatation of the pancreatic duct with fatty replacement, with pancreatic parenchymal atrophy and fatty replacement. There is a well-defined approximately 3 to 3 centimeter mass in the head region of the pancreas, which is showing loss of fat plane with the medial wall of the second part of the duodenum. There's also dilatation of the common bile duct You can see the mass at the head of the pancreas is causing an abrupt cutoff of the main pancreatic duct as well as the common bile duct, giving the classical double duct sign. Few fine calcifications seen within the mass. The mass is abutting the superior mesenteric vein with a resultant contour deformity and beaking of the superior mesenteric vein. There is a clear maintained fat plane of the mass with the inferior vena cava as well as with the portal vein. There are few soft tissue density masses which are seen involving the cranial as well as the caudal aspect of the body of the pancreas as well as in the tail region of the pancreas. The mass in the cranial aspect of the pancreatic body is appearing to encase the left, encasing the left gastric vein. Coming to the arterial phase, there's no evidence of any enhancing mass lesions within the pancreas. The mass in the head of the pancreas is appearing hypoenhancing. It is showing a clear fat plane with the aorta, with the superior mesenteric artery, as well as the common celiac axis and common hepatic trunk. There's no evidence of any pseudoaneurysms.
Right. So go to the head of pancreas, focus the head of pancreas, and tell me your differential diagnosis.
You can see there's a well-defined hypoenhancing mass in the head of the pancreas, which is causing a contour deformity of the superior mesenteric vein, as well as infiltration of the medial wall of the duodenum with a resultant double duct sign. So my first differential would be that of a pancreatic ductal adenocarcinoma of the head of the pancreas. Because of the vascular infiltration as well as the double duct sign, it's more in favor of a malignant etiology rather than a benign.
Right. So let's discuss each finding in detail here. Now let's, before going to the mass as such, let's discuss the background pancreatic parenchyma. So what do you think is happening in the background pancreatic parenchyma?
So there's complete atrophy of the parenchyma, which is replaced by fat. And there are also multiple chunky calcifications in the region of the duct as well as in the region of the parenchyma.
Right. So we have both intraductal and intraparenchymal calcifications. The main pancreatic duct is dilated to 18 millimeter. There is almost complete atrophy of the, fatty replacement of the parenchyma, but the volume of the pancreatic parenchyma seems to be maintained, or the fatty replacement seems to be more compared to the parenchymal tissue as such. Right? There's not much of, so you can call it probably a hypertrophic fatty proliferation, more than probably the actual parenchyma. Okay, or almost equal to the background parenchyma that we are expecting. Right. So where do you find these features common?
So it occurs in the case of chronic calcific pancreatitis.
So in chronic calcific pancreatitis, does the duct dilate up to 18 millimeters?
No, sir.
Not commonly seen.
Not common.
Where is it commonly seen?
So in the case of chronic calcific pancreatitis, chronic calcific tropical pancreatitis, or in case of an intraductal papillary mucinous neoplasm.
Okay. So a chronic calcific pancreatitis would have a dilated duct, yes, which would be more dilated when it comes to a chronic, when it comes to CA pancreas, and even more in case of IPMN, or as you say, tropical pancreatitis. So why do you think is it more in a case of cancer as compared to pancreatitis?
Because it causes obstruction of the duct.
So both the diseases are causing obstruction.
Yeah.
Right. So in chronic calcific pancreatitis, there is repeated inflammation. So that duct will undergo fibrosis. So that duct is not going to expand as much. When it comes to a carcinoma of pancreas, it is going to get distended. There is no inflammation happening there. The duct is just getting distended because of the enzymes, the fluid that is getting collected. Right? So that's why it's more in case of a chronic, in a CA pancreas. In IPMN, it is even more because it's just mucin which is getting secreted and dilating the duct. Right. So we feel there is a chronic calcific pancreatitis with what is your opinion about the head of pancreas lesion?
So it's more likely to represent a malignant mass.
Why so?
Because of a double duct sign, the significant ductal dilatation, and also the vascular.
What would be another close differential for a head of pancreas mass in a case of chronic pancreatitis?
It could be a mass-forming chronic pancreatitis. Which is
so how do you differentiate?
So in a mass-forming chronic pancreatitis, there will be the duct tapering sign which will be seen, where the pancreatic duct will be smoothly tapering and will be seen coursing through the lesion. Whereas in case of an adenocarcinoma, there will be an abrupt cutoff of the duct.
Yeah, so there will be an abrupt cutoff with shouldering, whereas when it comes to a duct penetrating sign, there will be just smooth tapering towards the narrowed segment, but you can still trace the narrowed segment of the duct. Right? So this again favors more of a carcinoma pancreas. So chronic pancreatitis with probably a carcinoma head of pancreas. What about the other lesions that you mentioned, the other 3 lesions around the duct?
Yes, the other lesions are not showing significant enhancement, and the lesion in the cranial aspect of the pancreatic body is causing encasement of the coronary vein, the left gastric vein.
Yeah, so you see the same beaking that you're seeing around the SMV.
Yes.
Right. So what possibility would you consider here? What should be your first possibility if that is not the coronary vein encasement is not there?
Then the first possibility would be that of a remnant pancreas which has undergone an inflammation.
Yeah, correct. So in this situation, what else would you consider and why?
In this situation, because of the vascular encasement, again we think of a adenocarcinoma. These soft tissue
also. Right. So also use the points that are favoring such a possibility would be the presence of soft tissue enhancement. There is no collection as such. There is only soft tissue enhancement, which is also causing encasement of a vein. And also, additionally, you can see that almost the entire pancreas is replaced. There is no pancreatic parenchyma left to produce something like a pancreatitis. Probably explain the reason why amylase and lipase is also normal, right? So here you can consider the possibility, definitely as a differential only, the possibility of a ductal
adenocarcinoma.
Multifocal ductal adenocarcinoma, which is also common in a case of chronic pancreatitis, especially in tropical pancreatitis, right?
Yes.
So with these differentials, how would you like to proceed? Before proceeding further, do you think this is operable, resectable? Because the diagnosis should have the primary diagnosis, the differentials, and in this case, since we are suspecting cancer, the resectability.
So the lesion at the head of the pancreas is unresectable as there is encasement of the first jejunal branch of the superior mesenteric vein. So when there is involvement of the first jejunal branch of superior mesenteric vein, it becomes an unresectable lesion.
Yeah, so in carcinoma pancreas, we have 3 categories: resectable, borderline resectable, and unresectable. The borderline resectable is primarily for venous involvements, where it depends on the surgical expertise available in each institute, whether it can be surgically reconstructed or not. Surgically non-reconstructable venous involvement include main portal vein involvement close to the bifurcation, main portal vein with SMV involvement extending up to the first jejunal branch, because that cannot be reconstructed. Right. So fine. So the radiology part is over. What would you like to suggest to the patient to differentiate the differentials that you have enumerated?
So endoscopic ultrasound with sampling can be done.
Right. So endoscopic ultrasound and sampling to confirm whether it is malignant or not. And what other differential will you consider, especially because of the hugely dilated main pancreatic duct?
So an IPMN.
IPMN. Can IPMN have enhancing soft tissue masses?
Yes, sir.
Yes. So you can have ductal adenocarcinomas even in an IPMN. So these would be our differentials, and we would suggest a endoscopic ultrasound guided FNAC. And surgically looks to be unresectable.
Yes.
Right. So what was the EUS guided FNAC report?
From the endoscopic ultrasound FNAC, it revealed adenocarcinoma cells from the head of the pancreas mass.
Right. So with that, we conclude our case here. So that was our case and how to approach it and how to go about the differentials and further suggestions.
Hari sir, any remarks on the case? Any more questions? Sir, please unmute, sir.
Deepika, other lesions was talked by any biopsy or any other investigation? Only the head of pancreas mass has been investigated further by endoscopic ultrasound.
Yes, only the head of the pancreas mass was sampled, sir. The other lesions could not be sampled.
So, do you think that they are similar lesions, or is it another lesion which is inflammatory only?
As one of the lesions is causing a vascular involvement, so there's some possibility that it could be a malignant. No possibility that it could be a malignancy. Rather than a benign.
I think that the other lesions also likely to be malignancy, right?
Yes.
Okay. And yeah, just a moment, sir. There was, I think, one finding missed here. Was there something in the liver?
Yes, sir. So there were few wedge-shaped hypodense lesions in the subcapsular regions of segment 2, 4, and 7, which is appearing hypoenhancing on arterial, portal, and venous phase, and appears isodense in the delayed phase. So these are more likely to represent a transient hepatic elevation difference.
Right. So there have been some recent discussions about the presence of TAD, which becomes isodense in the delayed phase, especially in a case of pancreatic adenocarcinoma with vascular encasement. So these are being speculated, yet not yet proven, that these could be micrometastasis from the pancreatic adenocarcinoma, embolizing through the portal vein and causing TAD. Right. So these are still not a criteria for diagnosing as metastasis or to rule out surgical resection if it is feasible, but to be followed up closely.
Deepika, do you have the follow-up of this patient? What happened to this patient?
Ma'am, patient was on chemotherapy and surviving, just undergoing palliative care.
Okay. Yeah, that was an interesting case with multifocal adenocarcinoma in the case of chronic ulcerative pancreatitis. Okay, so thank you, Praveen, for that excellent discussion. You have covered almost all points in CA pancreas, including resectability and everything. So thank you for that. Now, shall we go to the next case, or do you have some extra companion cases to show?
We'll finish the next case and
then come back
companion
to
cases. Yes.
Oh, yeah. So thank you, Deepika. So let's go to the next case, Dr. Amjita.
Dr. Vijayamari can lead the discussion, right?
Yeah, yes. Yes, sir.
Shall I start, ma'am?
Yes, Amjita, go ahead.
Presenting the case of an 80-year-old male who came with complaints of abdominal pain and yellow discoloration of sclera. He had a history of weight loss. There was no history of fever, hematemesis, melena, or similar episodes in the past. There was no relevant past or family history. The physical examination.
Amjada, slow. You are very fast now.
Physical examination revealed icterus. His abdomen was non-tender. There was no other significant abnormality. The lab parameters were within normal limit, except for deranged liver function test. The total bilirubin was 5.1 milligram percentage, with direct bilirubin being 4. SGOT and SGPT was also increased. He came to our department for an ultrasonography, which revealed bilobar intrahepatic biliary radical dilatation and dilated common bile duct with echogenic contents within. There was no obvious CBD calculus with posterior acoustic shadowing. Calculus was noted in the gallbladder. However, there was no evidence of cholecystitis. He had prostatomegaly and a small posterior bladder diverticulum. So from the ultrasonography, the differential that we considered were either distal CBD calculus causing obstruction and sludge being accumulating in the common bile duct and in the biliary radicals, or a stricture in the distal CBD, or any mass lesions causing constriction at the level of CBD, or even blood products within the CBD. There was no history of hematemesis or hematochezia. So as a part of routine investigation, we actually advise the patient for an MRCP. In keeping in view the age of the patient and his difficulty in holding breath, the patient came for a CT abdomen. Ma'am, shall I show the CT, ma'am?
Please show the images, Sanjana.
Axial CT scan of abdomen. This is the plain axial CT scan of abdomen done for the patient.
Amjita, are you sharing the screen?
Yes, ma'am. Not seen. I'll just do it again.
Okay.
Ma'am, is it visible now, ma'am?
No, it's not visible.
Now, ma'am?
Yes.
This
Continue.
is the axial plain CT scan of abdomen done for the same patient, which revealed bilobar intrahepatic biliary radical dilatation. There is dilated common bile duct with soft tissue attenuation lesion within. We can also find that there is a radiodense calculus within the gallbladder. There was no radiodense calculus noted elsewhere in this CBD. The CBD distally was showing fluid attenuation within. The proximally dilated intrahepatic biliary radicals were also showing fluid attenuation within. Moving on to the thin venous phase. We previously said intrahepatic biliary radical dilatation is more prominently seen. We can see that there is an incremental enhancement of the soft tissue attenuation lesion previously documented in the previously seen in the common bile duct. There is also extension of the soft tissue density lesion into the secondary confluence on right side, while the secondary confluence on left is preserved. We can also see that the left anterior segment of the portal vein is almost thrombosed, and there is perfusion defect in the right anterior segment with capsular retraction. There is a segmental predilection for the intrahepatic biliary radical dilatation as well. Looking into the vascular anatomy about the arteries. We are able to appreciate that the lesion is in close contact with the right hepatic artery. However, there is no evidence of luminal narrowing, irregularity, or thrombus within it. The right hepatic artery is not having any variant. It is directly coming from the celiac trunk as well from the proper hepatic artery arising from the celiac axis. So now looking into the hepatic vein. We can see that the hepatic veins are far away from the lesion and it is not involved. There are few periportal lymph nodes noted with a maximum diameter of 6.5 mm. The rest of the liver parenchyma was looking normal. There was no other enhancing lesions within the liver parenchyma elsewhere. There was no evidence of any significant pulmonary nodules or any skeletal metastasis. Few other axillary findings like there is a hiatus hernia, the GB calculus without evidence of cholecystitis, thinning of bilateral renal cortex, the prostatomegaly, and a small posterior bladder diverticulum, probably secondary to the chronic obstruction, is also seen. So from the as far as the lesion is concerned, there is no other significant findings from this CT study.
How do you conclude the case, Sanjana?
Taking into consideration the age of the patient, 80-year-old male with bilobar ISBRD with soft tissue attenuation lesion within the intrahepatic within the CVT extending into the right secondary confluence and left primary confluence. The possibilities to be considered include either intrahepatic intraductal cholangiocarcinoma or an intraductal metastasis. However, we were not able to appreciate any primary malignancy elsewhere in the abdomen. So a possible differential at a higher point will be intraductal cholangiocarcinoma and the Bismuth-Correll classification type 3A.
Okay, basically this is I think the metastasis should not come in the first differential that you have mentioned. It's cholangiocarcinoma occurring in this location is far more common than metastasis, right? So I think you should not mention both with giving equal importance to both. That's one thing. And again, the primary confluence is involved and the right secondary confluence is involved, right? That's what you meant. And the left secondary confluence is paired. So that you have mentioned correctly. So what is the implication of this mentioning the involvement of the confluence, secondary confluence on the right side and sparing of the secondary confluence on the left side?
Ma'am, based on the confluence involvement, we have to plan the hepatectomy, ma'am. If the right secondary confluence is involved, it becomes Bismuth-Correll classification 3A. So we can proceed with the right hepatectomy with hepaticojejunostomy. If it's a left secondary being involved, then a left hepatectomy. If both are involved, then it becomes BC type 4, which is unresectable.
Okay, so what was the treatment given for this patient? Was it right hepatectomy? Did they proceed with right hepatectomy here?
Yes, ma'am. They proceeded with the right hepatectomy.
Okay. Basically, the BC system classification is being used in most of the centers, but there are some limitations in that it does not include the vascular invasion. So it's always better to discuss with the gastro team in our hospital before proceeding with the classification. Okay, mentioning about the classification. So the BC system has some limitations, which is that is why the gastro is not using this system for treatment planning. So they always incorporate the vascular invasion, presence of lymph node mets, distant metastasis, everything together, like MSK-CC classification for treatment planning. Okay, so again, what are the other resectability criteria that you need to mention in your report for treatment planning?
If there is a variation in the biliary anatomy, like for example, if the right posterior is coming directly from the common hepatic, or then we can do a trisectomy, trisegmentectomy, or any variation in the biliary anatomy, any variation in the hepatic vein or portal venous system anatomy.
Okay, so that you mentioned that in this case there was no variant anatomy, right?
Yes, ma'am. No variant.
The right anterior and the posterior ducts were seen separately. joining into a common right depth, right?
Yes.
So what else will you mention in this report? Other than the vascular invasion, the longitudinal extent of the tumor?
About the metastasis, about any other lesions aside this?
Yes, presence of lymph node metastasis, extrahepatic metastasis elsewhere, that also you mentioned. Other than that, to proceed with right hepatectomy, what will you mention in the report specifically? Something else?
Supply.
Yes, arterial, I'll come to it directly. So here we have to mention about the remnant liver volume, which will be there once the right hepatectomy is performed. Otherwise, if the left, here in this case, the left lobe is markedly hypertrophied, right? So proceeding with the right hepatectomy is going to be relatively easier for them, in that if the left lobe was smaller in size, or if it had atrophy, then the post-op morbidity mortality will be very high. Okay, so it's always better you mention about the liver volume also, about each lobe. Okay, so other than that, the presentation was okay. It was very good. And differentials, for sake of differentials, you can always mention that metastasis, intraductal metastasis is a differential diagnosis. And one more question I would like to ask yours, that's very commonly asked in all the PG exams. How will you differentiate the benign and the malignant strictures?
Ma'am, in case of the malignant stricture, the length of involvement will be more than 1.2 centimeter. Okay. And the wall thickness will be more. It will be more than 15 millimeter. And the wall thickness will be, the wall that is being involved will be irregularly thickened. And in case we are taking MRI, these can show a diffusion restriction. And on contrast phases, these can show incremental enhancement. If it's a larger lesion, even if we do a PET scan, we'll be able to pick up with a higher SUV. Smaller one, we may not be able.
Yes, basically it'll be long involvement. That's more than 1.2 centimeter, and the wall thickness more than 1.5 mm. It's almost always malignant. Yes, of course, you mentioned about the other points also, the incremental enhancement, the use of other modalities like MRI to look for diffusion restriction and increased SUV in the PET. So are we showing, okay, that concludes the case, and the patient underwent right hepatectomy, right?
Yes, ma'am.
So
is there CLD in this patient? Because some widening of fissures are seen.
Ma'am, it is mentioned in an early CLD, ma'am. It is not a known case, and ultrasonography also did not reveal any features of chronic liver disease other than left lobe hypertrophy and fissure widening. We did not proceed with the fibroscan. So
yeah, actually that has some implication in the surgical management of this patient, right? Because that is important, because post-op morbidity again increases if there is a chronic liver disease. Okay, so as Hari sir, any more remarks on this case?
Nothing more. She can continue with the companion case, right?
Okay.
ma'am, is my screen visible, ma'am?
Yes, it's visible.
So this was yet another patient who presented to us with obstructive jaundice. This patient also had bilobar intrahepatic radical dilatation on ultrasonography. So this patient, she underwent contrast enhanced CT studies, which revealed bilobar intrahepatic radical dilatation with smooth enhancing stricture at the region of the mid CBD, while the distal CBD was again showing fluid attenuation. So this was a finding. There was bilobar intrahepatic radical dilatation. There was a constriction at the level of mid CBD. There was an enhancing peripheral wall thickening at the level of mid CBD, with distal CBD showing normal fluid attenuation. So this came out to be a case of periductal infiltrating type of cholangiocarcinoma. This is the next case. This was a female patient who presented with obstructive jaundice. Ultrasonography revealed a heteroechoic lesion in the left lobe of liver. On CT scan, we were able to find that this lesion is showing enhancement in the delayed phases with capsular retraction. And this came out to be a case of mass-forming cholangiocarcinoma. So these were the 3 types of cholangiocarcinomas that we met.
So what was the HPR report in the first case?
Intraductal cholangiocarcinoma, ma'am.
What type was that?
Papillary type.
So basically, the other 2 companion cases, one was a mid-CVD periductal infiltrating type of cholangio, and the last one shown is a mass-forming type of cholangiocarcinoma. So that covers mostly all the types of cholangiocarcinomas. And so we can proceed with the companion cases of Deepika. Next.
I'm actually not companion cases related to pancreas, ma'am. There's 2 other interesting cases from Gokulam.
Okay, you can go ahead.
Respected sir. Ma'am, is it visible, ma'am?
Yes, yes. You can introduce yourself and then start.
Respected sir and ma'am, I am Rahul, radiology resident from Sri Gokulam Medical College. Today I am going to describe the various features of CT hypoperfusion complex, and the images were taken, representative images from the patients came in our department. First describing the various signs of CT hypoperfusion complex. First, the vascular signs, the flattening of the inferior vena cava, the IVC flattening with anteroposterior diameter of less than 9 millimeter, which is measured in 3 consecutive segments. First is 20 millimeter, about 2 centimeter above the level of renal artery, 2 centimeter below the level of renal artery, and also at the level of perihepatic portion. The incidence rate of this finding in patients with severe hypoperfusion is about 77 to 100%. Here is a sagittal section of the venous phase. The measurements are taken where it is at the level of renal artery, renal vein, joining of renal vein, about 2 centimeter above. The AP diameter was 7.61, and below 2 centimeter it was 8.19 millimeter, and the perihepatic portion it was 6.95 millimeter. This was the axial section showing the AP diameter 5.69 millimeter. Next one feature is a small caliber of iota. A small caliber abdominal iota with its anteroposterior diameter less than 13 millimeter. It is also measured at the level of renal artery, about 20 millimeter above and 20 millimeter below the level of renal arteries. The incidence rate of this finding is about 20 to 48%. Here there is a reduced caliber of iota in the axial section, 1.14 centimeter. It's above the level of renal artery, it is 1.07 centimeter, and below the level it was 1.01 centimeter. The halo sign, the presence of a low density fluid that is less than 20 HU surrounding the IVC. It's in the incidence rate of this finding is 77.8%. Here we can see a thin rim of fluid surrounding the inferior vena cava due to the increased permeability of the vasculature. This is the IVC halo sign is seen. Next, coming to the shock bowel, the small bowel fluid filled dilated tubes with thickened walls, the thickness of more than 3 millimeter. due to edema of the submucosa and increased mucosal enhancement. Its incidence is 40 to 70%. Here we can see the thickened jejunal loops with maximum diameter 7.5 millimeter, and also see the mucosal enhancement. Mucosal enhancement of gallbladder is another feature. Mucosal enhancement without the thickened gallbladder walls. It is seen in 33% of patients. And we can see the gallbladder walls are not thickened, however, there is mucosal enhancement of the GB wall. Now, coming to the parenchymal signs, there is abnormal renal parenchymal enhancement. There is increased and the parenchymal enhancement is increased and prolonged, and its incidence is 55.6%. There is also abnormal adrenal hyperenhancement, bilateral hyperenhancement of the adrenal gland. Here, the coronal sections showing there is hyperenhancing kidneys, and also you can see the hyperenhancement of the adrenal gland. There is abnormal liver enhancement, a reduction of hepatic enhancement, that is 25 Hounsfield units less than that of the spleen. Its incidence is 4 to 11%. There is a non-contrast image. We measured the average Hounsfield unit of liver to be 58 and the spleen was 51. And post-contrast, the images, the liver, it was 115 and the spleen was 146. Therefore, the enhancement there is less than 25 HU compared to the spleen. Next feature is peripancreatic edema and abnormal pancreatic enhancement. It is shock pancreas and abnormal post-contrast higher attenuation than the normal density values, 20 Hounsfield units greater than that of liver and spleen, often with peripancreatic low density fluid. Its incidence is more than 44%. Here, in the non-contrast image, the pancreas average Hounsfield unit was 35, and on post-contrast images it was 155. The enhancement was calculated to be 120. These were very much higher than that of the liver and spleen, more than 20 HU higher than that of liver and spleen. The thin rim of peripancreatic fluid can be seen here, which was about 7 HU. Other features, non-specific features include ascites, we can see perihepatic and perisplenic free flowing. Thank you, ma'am.
Actually, it touched upon a very important topic we sometimes overlook in CT. So, thank you. Hari sir, any remarks on this? Sir, please unmute yourself.
Rahul has repeatedly described the incidence rate. What does it mean, really? Incidence rate of many criteria being described in hypoperfusion. What does it really mean?
The incidence rate in the it is actually the sensitivity. The sensitivity. Hello, sir.
Yeah, you can.
It is actually the sensitivity of using if we use the flattening of inferior vena cava as a test in detecting the patients with severe hypoperfusion, then there is 77 to 100% sensitivity.
Yeah. So you can easily or comfortably translate that incidence rate into sensitivity, right?
Yes, sir.
Right. Any other cases? Any interesting cases?
Oh, yes, sir. One more case is there, sir.
Respected everyone, I'm Shruti Prakash, radiology resident of Sri Gokulam Medical College. And I would like to discuss another case of congenital nasal pyriform aperture stenosis. This is a rare cause of neonatal nasal obstruction. The importance is that it should be differentiated from the choanal atresia, which is the most common cause of neonatal nasal obstruction. So this case was diagnosed in our department. So coming to the brief about the congenital nasal pyriform aperture stenosis. So congenital pyriform aperture stenosis is a rare cause of neonatal airway obstruction that clinically mimics choanal atresia. The differentiation between these two are very important because the management of these two conditions is different. And congenital pyriform aperture stenosis, they can present as an isolated form or it could be associated with other craniofacial abnormalities. The modality of the choice for the investigation is the CT. When coming to the anatomy, pyriform aperture is a bony inlet which is formed by two nasal bones and maxillary bones. It is the narrowest and anterior-most part of the nasal cavity. So the measurement of the pyriform aperture width is important and it is taken between the medial aspects of the nasal process of the maxilla at the level of the inferior meanders. It's a very simple and accurate method for diagnosis, and this single measurement itself is useful for the diagnosis of the condition. When the width is less than 8 mm in a term infant, it is considered to be diagnostic. Other associated findings include medial angulation of the nasal process of maxilla, solitary central megaincisor, and MRI is also recommended to exclude other associated anomalies such as hollow prosencephaly and anterior pituitary abnormalities. So in our department, the case was diagnosed, and it was a case of a male baby. He was appropriate for gestational age, born at full-term vaginal delivery to a non-consanguineous parents. His ABGA score was 9 at 1 minute and 10 at 5 minutes. No active resuscitation was required at the time of delivery. There were no maternal comorbidities, and the antenatal period was uneventful. Clinically, no craniofacial abnormalities were also detected. But soon after the delivery, he presented with severe noisy breathing and nasal block. On the postnatal day 1 itself, 15 minutes after delivery. Number 8, nasogastric tube could not be also passed to the right nostril. So for which ENT consultation was done, and there was a clinical, actually initially there was a clinical suspicion of choanal atresia was made out, but CT PNS was taken out to evaluate the upper airways, and the diagnosis came to be the pyriform aperture stenosis. So this is actually the CT axial section bone window that is showing a normal pyriform aperture in an infant. So this is the nasal process of the maxilla, and we take this width between the medial aspect of the nasal process of the maxilla. This is the normal pyriform aperture width. Then the pyriform aperture width is less than 8 mm in a term infant. It is considered to be the stenosis of the pyriform aperture. So in our baby, we take the measurement between the medial aspect of the nasal process of the maxilla, and the pyriform aperture width came to be 3.8 mm. And it is diagnostic of pyriform aperture stenosis, and also there was associated finding, there was a medial bowing of the nasal process of the maxilla. Associated another finding include the solitary medial maxillary central incisor. And also there was a triangular hard palate. So the measurement itself was diagnostic for the pyriform aperture stenosis. And we had 2 more findings: solitary median maxillary central incisor and triangular hard palate. So whenever there is a solitary median maxillary central incisor, in order to rule out hollow prosencephaly, we have to take a MRI. So MRI was also taken in our department, and this is the MRI showing a partial fusion of the thalamus in the midline. Otherwise, no significant abnormalities was found out. This is a CT image of the same baby, and here the bony choanal width is now normal. If it is only less than 3.4 mm in a children less than 2 years, it is diagnosed as choanal atresia. Here, the bony choanal width was 11.8 mm, so there was no evidence of bony or membranous plane. The main differential diagnosis for the pyriform aperture stenosis is choanal atresia. So choanal atresia is the most common cause of neonatal nasal obstruction. It is due to the lack of formation of choana, that is a communication between the nasal cavity and the nasal pharynx. So radiological features for the choanal atresia is a narrowed area which is less than 3 mm, and the measurement is done at the level of the pterygoid planes in the axial plane, and there are associated medial bowing of the posterolateral wall of maxillary sinus and also the thickened Bowen bone. So our case, it is concluded to be the congenital nasal pyriform aperture stenosis. This was an interesting case which is presented recently in our department. Thank you.
Yeah, that is indeed a very interesting case. And you have also told how to differentiate that from choanal atresia, because that's the first thing that we think when a neonate comes with the airway obstruction. Yeah. Any remarks, sir?
You said when looking at the MRI study, there is a partial fusion of the thalami. Is it suspected only, or is it convincingly diagnosed?
There was only suspicion of partial fusion of thalami in the midline, sir, and in the anterior aspect.
Yeah. So
any 3D sequence was taken for this to confirm, or it was difficult to get because this is a neonate? Because we can confirm in a 3D sequence whether there is actual.
Already was very difficult to get, ma'am.
Yeah, that's all. But this is actually an associated feature of that. Is this mentioned as a associated feature?
Yes, ma'am. Because pyriform aperture stenosis, whenever there is, it can be present as an isolated form and with associated abnormality. So we had an associated abnormality of a solitary median maxillary central incisor. So if there is a solitary median maxillary central incisor, MRI is always indicated to rule out holoprosencephaly. But in this baby, holoprosencephaly was not that much diagnosed. Only we have a suspicion of a partial fusion of anterior aspect of the thalamic.
Any more cases to be shown?
It's all about it's all, ma'am.
Okay, so thank you so much. All the residents, actually, Dr. Deepika, Amjita, Rahul, and you, everyone has wonderfully presented the case really well. And all were interesting cases, and even actually you have included 2 PPTs also included with the case presentations. Very well done. That case presentations were excellent, and I thank Hari sir for moderating the whole session. I thank Dr. Praveen and Dr. Vijay Kumari, both assistant professors from Gobalpur Medical College, the way they've guided the PTs throughout the session. Thank you so much. You've included like almost all the points that examiner asked in exam. So thank you, Dr. Praveen, thank you, Vijay Kumari, and thank you, Hari sir, and thank you, residents. And I thank Venu sir is there, sir.
Yeah.
So I thank. Say any more remarks. Shall I? Okay.
Just one point. Regarding the first case now, the pancreatic malignancy. Dr. Deepika said the route of biopsy or FNAC of pancreas is endoscopic. So just I'm asking whether any other route is there apart from this endoscopic. Endoscopic anyway we cannot do now. So as far as radiologist is concerned, is there any other route which you can do for pancreatic mass? Endoscopy, of course, will be done by gastroenterologist now. So when the case is lying in front of you and you are suspecting pancreatic malignancy, and what you can offer to that patient as a radiologist? I think my question is clear.
Yes.
Yeah, probably the question is why the other 2 lesions are other lesions were not.
No. It's not. No, the thing is that actually she said the endoscopic ultrasound guided FNAC was done or biopsy was done for this particular case. No.
Yeah.
So what you can offer? That's my question. Endoscopy by the gastroenterologist.
Yes. Percutaneous biopsy, root causes of tumor tract along the nasal path.
Percutaneous. Actually, that should be the one that actually we have to do now, because this is very cheap. the endoscopic ultrasound, I don't know how much the patient is being charged for that. So what's the problem in doing percutaneous FNAC? Is there any problem?
There can be tumor tracking along the path of the needle.
That can also happen with the endoscopic ultrasound. They have to go through the posterior wall of the stomach. Here you have to go through the anterior wall and then posterior wall. That's all. In endoscopic also you have to go through the stomach now, or duodenum, wherever it is.
So, but then in endoscopic ultrasound,
no, transgastric approach is actually transgastric approach is actually it is a standard one, transgastric approach. Here actually we don't have to bother about this seedling and all, because when we do FNAC, when the case is not a case of surgery, it is not a surgical candidate. At that time, actually, we consider FNAC. So if a mass is there, which is resectable, then immediately the patient will be taken up for surgery. Okay. So when the surgery seems non-resectable, at that time, actually, we are going for FNAC to confirm malignancy so that the patient can be given chemo. Okay. So at that time, actually, we don't have to bother about much about the seedling and all, tri-seedling and all. That is one thing. And second thing, the transgastric approach is a standard one. So we can do percutaneous transgastric FNAC. Even biopsy you can do, but biopsy will be a little more painful. But in certain situations, actually, biopsy is indicated, not FNAC alone. Biopsy is indicated. In what condition of pancreatic malignancy, you have to go for biopsy, not FNAC alone. Otherwise, for adenocarcinoma and all, actually, FNAC is enough, more than enough. But in certain pancreatic malignancy, biopsy is indicated. Which one? If you suspect pancreatic neuroendocrine tumors. For pancreatic neuroendocrine tumors, actually, one has to go for immunohistochemistry and all. For that, actually, the pathologist needs a core of tissue. So for that, actually, we have to go for biopsy. Even for biopsy, no. Again, you have to see whether you can do percutaneously, because sometimes you can get a window. You need not go through the stomach. No. So sometimes you can go through the liver, or sometimes you can go below the pancreas and then angulate it, and then you can reach the lesion. So there are first you have to see whether you can do it. And if it is not feasible, then you can send the patient for endoscopic ultrasound guided procedures. Okay, thank you.
Yes, sir.
Thank you, Venu sir. He's an expert in image-guided FNACs and biopsy. Thank you, Venu sir.
So one minute, Dr. Venu. Is there any risk of pancreatitis in pancreatic biopsies?
The thing is that once you take the biopsy, if you take the biopsy from the pancreatic mass, no, the risk is less. Suppose you take biopsy from the normal parenchyma, then there is chance for leaking of enzymes, pancreatic enzymes. In that case, it is there. But if you specifically take it from the mass, then the chance of pancreatitis is very less. That is why, as a first step, actually, you have to go for FNAC, not biopsy.
Yeah.
So we have to go for FNAC, and most of the time FNAC that's enough. But suppose it's not enough, they want more specimen and all. In that case, actually, we can, considering the risk, we can go for biopsy, either percutaneously or endoscopically.
Okay, so thank you, sir. I think there are no questions in the chat box or in the question and answer session. I think we can wind up the session, right, sir?
Right.
Hi, sir.
Yeah.
So I thank everyone for attending today's session. I thank Venu sir, the academic chairperson, for the smooth conduct of this session. I thank Ramesh Shenoy sir, who is the man behind, who is the program coordinator of all the Kerala academic sessions. I thank Gomadi ma'am and Riju sir, both are not with us today because of their personal reasons. So they are the one who is actually conducting, who is actually in front of conducting such a smooth academic session throughout the year. Thank you. I especially thank the MedPiper team for the smooth conduct of this session without any technical glitches. Thank you so much. And thank you all the residents and all the attendees who have attended today's session. Hope it was useful for all of you. So our next section will be on Saturday, 5th March at 5 p.m. So we will have a talk on the biliary diseases by Dr. Rajiv Anand, who is the head of department MOIC Medical College, Kochi. So please do join for that. So thank you once again, and we can wind up the session. Thank you.
Thank you, ma'am. It was indeed a very informative session, and hopefully in the next session, all the attendees will continue learning more. Thank you.
Thank you.